So that's great. So there's a bunch of places we could go in the final 15 minutes. Maybe I will start with a question. I'm going to try to think of questions that might cross across a couple of you. So Laura spoke about the desire to see sort of multidisciplinary efforts. And one of the things that we think about a lot in our group as an unrealized promise thus far is that a lot of machine learners apply machine learning to data that already exist because that's what they get. And it's inside their comfort zone to run reinforcement learning models or to run unsupervised learning models on patients that already did or did not have sepsis. But one of the things that might be best might be to think about more sophisticated prospective deployment, where one could, for example, in reinforcement learning models, actually have true stochastic policies, sort of like live multi-arm bandits, which is basically very fancy randomized trials that could be nested within particular phenotypes. So that's like a little bit of a head spin for many people, but it's about taking RCTs and joining them up to the prospective deployment of so-called online learning for policy learning, where you would have true stochastic distributions instead of just assumptions of randomization. Now, today, when I listened to the machine learner folks in that last session, they were largely still in the world of probing mimic and are always going to be tripped up on causal inference. And you started Michael, by talking about things that machine learning won't help with, but I might push you and say machine learning as it's currently being deployed won't necessarily help. Could you envision a future where companies like Google, et cetera, could be partnering with healthcare systems for prospectively deployed learning models? And that would definitely be range, as alluded to by Laura. I'm putting people in a room together that have not been in a room together. And then you might actually start to get better learning from AI tools.
Not a difficult question at all, Derek. Thank you. So I agree. Let me say that I agree with the premise of what you said, which is that there's a lot of effort around causal inference, whether it's RL or kind of other reinforcement learning or other based things, to try and do that out of historically collected data. And I think that there's a lot that we'll learn there, but I think that there is a ton that is brought from the tradition of healthcare of understanding that prospective studies that have the ability to make causal inference, like in randomized ways, are for many things the only way that we'll ever really truly find out what the effect is. And what I heard in your question was disentangling two things. So one is evaluating a new system or a new medical device using traditional methods in randomization. And that device could be, a new catheter, it could be a new algorithm, it could be other things, which we think is really important to do. The other is using ML in and complex adaptive trial design. And I think that there's a lot of research to be done in that, where having a bunch of the Bayesian adaptive trial folks and reinforcement learning or other machine learning causal inference folks, I think it'd be really good to get them together and to work on it. One of the things over the past few years I've learned is that stuff I learned in epidemiology and biostatistics land has the same concept in machine learning. They just use precisely different words for it, so much that, when I teach about this, I actually have a translation table between machine learning and epidemiology. So I think there's a lot there.
So if the Gordon and Betsy Moore Foundation had money to burn on this area, what would it take to get Google or other technology companies joining up with Laura or with MedStar to go after? Is that where we're going? Is that how we should be spending our money? This could be to anyone. Or should we spend the money completely differently? I keep on coming back to this 10 million because it was suggested. It could be, maybe we need 100 million. Christine, you definitely felt like there's a shortage of cash.
I was nodding, and 10 million used to sound like a lot of money. It doesn't sound like nearly enough now, the world that we're living in. I think there is space for that. And I think those sorts of partnerships should definitely be explored. So I think there is potential there. For me, the part of the tension within health systems still is those things are going to deliver on future promise, but we also have real issues today that we need to deliver on as well. And so I think the combination of exploring those kinds of partnerships at the same time as we're exploring, I was struck, Foster, when you were talking, because one of the things we did in some of our sepsis work is to try and really begin to teach signs and symptoms through our patient and family advisory councils of sepsis and arm patients just with a simple question, which is, when you see your clinician with these kinds of signs and symptoms, ask the question, could this be sepsis? Just to pique the curiosity, or to put it in front of providers. And the sorts of responses they got were eye-opening, in terms of both some clinicians who saw that sort of as helpful, and other clinicians who saw that as intrusive, and other clinicians who saw that as like, that's my domain, not yours. And so I think $10 million needs to be split up a couple different ways, because I don't think technology is going to deliver what we need completely. And I think there's a lot of things that need to be delivered simultaneously in the sepsis space for organizations, for health systems. We need to have leaders aware that sepsis is a big problem and that it keeps clinicians awake at night. To Daniel's point, it's not the patients that are in the hospital. It's the ones that we sent home from our 300 ambulatory sites. The patients that we wonder about, that keep us awake at night, that sometimes we don't know.
So that goes back to a point that Daniel had brought up in his remarks, and maybe I might pivot that to a question that's actually come in from the audience, which is somewhat linked perhaps, and that is, when Daniel sends someone home, or when anyone else is sending someone home from an ambulatory center, one part of the sepsis diagnosis relates to this issue of, is the patient infected? And of course, our gold star assessment for determining for ruling someone in is a culture that might not be available for, say, 12 or 24 hours. And so the decision needs to be made in advance of having a rule in. Of course, arguably you send someone home because you've comfortably ruled out infection, and that relies on judgment. So someone in the audience has said, well, wait a minute, there is now the direct from blood diagnostics. And so, for example, apparently CMS is now reimbursing hospitals for their the T2 program from T2 Biosystems for their T2 bacteria utilization through the NTAP program. So I wonder whether, and this is a question to anyone of the panelists, do you see that we are in the already with CMS's approval of the T2 system? Do we think that is already prime time ready and can actively play a role because of the rapid result? Or do we actually think that there are still important challenges for those kinds of technologies? Perhaps they're not adequately sensitive enough to function as a true rule out and so on. So thoughts, anyone? Daniel, in your emergency medicine physician hat, or Laura, UW?
I'll take a stab at it and see what people want to add or say differently from that. I think these are great technological steps forward. I think Chris, you just alluded to it. I don't think technology alone is ever going to be the answer that I think we're looking at how things work together, right? So how Daniel's clinical assessment in the emergency department using probably streams of measurable data that gets reported, and also using other inputs that never end up in the EHR that, he can't really parse out, but that sort of, irreplaceable, I think at this point, sense of clinical judgment at the bedside that either the bedside nurse has, a family member has at the bedside, or the patient, or, a clinician that says something's not right here. And those are things that I think are really hard to capture in the medical record. And I think they reflect a limitation of where we go with a lot of EHR-based research. I think all of these tools are potentially complementary, but none of them are standalone. And so I think to link it back to what you were saying earlier, Derek, in terms of how do you integrate these efforts in a way to capture all of these different pieces? Because I think that's how we move forward in terms of taking better care of patients and improving diagnostic excellence. Now, I'm not smart enough to design a study that does that, but I think those are all components that feed into it rather than a single piece alone. And I recognize that all these pieces need to get built before they can plug into a larger study per se. But I think that's the ultimate goal of taking all of these pieces and trying to link them together in a way that really moves patient care forward.
Can I jump in?
Yeah, please do.
So I was compelled by the data that was shown on the visits that people have prior to being diagnosed in an inpatient setting with sepsis, and coupling that with Helen's comment earlier in the day about the lack of precision, really, about instructions to patients. I mean, Chris, you talked about, I think, some of the ways in which awareness and could this be sepsis as a singular question has been really helpful in a lot of advocacy organizations. I know the Staunton Foundation has really advocated that. But what's the specific, not only instructions, but ways in which patients, after they're seen, could be enlisted to help with that diagnosis during that outpatient living at home time? There are, I think, some promising technologies. I mean, even, basic things like, wow, it may be a telehealth visit, where somebody is actually visualizing and or the kinds of things that people may have at home to help with diagnosis, things that we're aware of, things that, the kinds of things that increasingly people used in the era of COVID, like here's my O2 saturation rate, over time. I mean, that may be an opportunity to couple some of this for either the patient, Daniel, that you mentioned that goes home, or the patients identified that are really have an interaction with the system, but then are maybe given an instruction that's not very specific or not very helpful, or not specifically a pathway in to enlist them as a help in early diagnosis.
There seems like it seems quite possible that because sepsis was the purview of intensivists for a long time, we thought that sepsis was a thing that we manage in a high intensity setting with lots of data, and it's only in the hands of professionals, and don't try this at home. And perhaps our mindset has locked us into not even thinking about the ways in which patients and families can play a really active role in early diagnosis. Or I think it was Michael who, in giving the example of his father, might say, how do you prevent sepsis occurring in the first place? And I know that things haven't gone so well of late for Rick Bright at BARDA, but actually BARDA, under Rick's leadership about 2 or 3 years ago, wanted to launch a campaign. It got derailed a little bit by COVID, but a Stop Sepsis campaign where they did actually start the question by saying, how can you avoid people getting septic in the first place? And what would be the innovations that take place so that patients never come to the hospital with sepsis? And it might be true that these things are more thinkable than we realize, and that we're a little bit trapped by the trappings of the traditional healthcare system. Doesn't even make us think about an acute, very intense condition like sepsis actually being something that could be owned as a community health problem by the community that actually gets sepsis. So we have just 2 or 3 minutes left. So I wonder, with 30 seconds each, If I could just ask each of you for a concluding remark about something that you take home from today that might have been something you always had thought about, but now you think about it in a more special way, or it's something that you hadn't thought about sepsis, and today completely caught you by surprise, and it's something you have to go and think about more. And maybe I'll go in reverse order this time. So, Michael, anything particularly resonating about today that's changed the way you're thinking about sepsis?
Yeah, I'll tell you two things I wrote down. One of which Daniel said, which is the risk of squeezing the balloon and causing unintended consequences in other areas, which I think is really important. And I'm thankful that the Moore Foundation and the National Academy are thinking of guarding against that. And the other is Laura's exhortation to show our work and to be explicit and intentional about the trade-offs that happen either in individual clinical care or in guideline creation. I think those are both wise pieces of counsel.
Perfect. Foster?
Boy, it's hard to pick and choose. There's so many, but I think that the comments of people, a number of people had about the reality of diagnostic uncertainty, and that for a whole host of reasons, that diagnostic uncertainty, at least with respect to sepsis, is going to be around for a while. So the goal is not, just in terms of frame setting or setting expectations, it's not going to be eliminated, and maybe shouldn't never be eliminated completely. The question is how much uncertainty in different contexts for different patients is acceptable, and how do we work to at least incrementally over time decrease that uncertainty? And that's a laudable goal, even if it's a forever goal. The other interesting thing, which I had not thought about, or had thought about a little bit in terms of thinking about Chris's work with phenotypes, but it was expanded thinking about it today, is how can we use the diagnostic data to better inform treatment? How does diagnosis and treatment go together in terms of all these new pieces of information in a way that we really hadn't thought about? At least for me, it's not diagnosis and then there's treatment. It's this blurring of the line between diagnostic data and the way in which it may inform in lots of different ways we haven't thought of treatment. I'll stop there. Thanks.
Perfect. Thanks, Foster. Christine?
Great. Very quickly, I think the concept of a learning health system that while we need to do intense work within our silos and our spheres of expertise, the progress is going to come if we don't let this work live in silos. That in fact it does, going back to Laura's comment, needs to be integrated. We need to show what we're doing. We need to take the science, blend it with the culture improvements, and communicate it to organizations that are not on this call today because they're delivering care in the country. So that learning health system piece.
Thank you, Laura. Thank you, Christine. Laura?
I want to come back to something that Hallie Prescott said during her session, that she just framed it in a way that I think I had sort of inklings of it before, but I thought the way she framed it was really elegant, which was to think also about how to explain the concepts of diagnostic uncertainty to patients and how that then makes patients a central owner in the process as well. And I think that was something that I will really take home from this and try to both incorporate into my personal practice, but also into the work we do more broadly.
Wonderful. Daniel?
I think that as a lay clinician, again, taking that perspective, this concept that there might be many different diagnoses of sepsis as opposed to a singular type of sepsis, whether you describe it as endotypes or however you describe it, is very resonant to me. So I look forward to the day when we can distinguish between those different subtypes of sepsis that have treatment implications. And I think this other discussion around really expanding the setting of sepsis diagnosis and care outside of the ER, outside of the ICU, and outside of the ward, and thinking about bringing that into people's homes.
Great. Well, with that, I want to thank all of you for your insight, your thoughts, particularly representing these different stakeholder opinions. It puts an almost a complete cap on the day. The final cap is going to be provided by our fearless leader and chair for the day, Andy Beinman, and we've kept Andy 3 minutes late. So that's my fault. I didn't chair the session quite tightly enough, but I really thank you all for all of your comments and for helping sum up what's been a wonderful day. Thank you very much.